Well, I am honored to be a part of this summit conference. It's a long time in coming for Ventura County, and it's nice to see so many other presenters and so many other people involved with this whole food, plant-based lifestyle medicine, well care approach to dealing with our health issues today. And so it's quite an honor to be presenting. So I'm going to give you a real brief thing about type 2 diabetes, and just had to do something, try to be funny about it, but the sweet news about type 2 diabetes. And I am going to build on what many of the presenters before me have done already. So we know that diabetes is going to take care of about, be affecting about 1 in every 10 people in the United States. And 1 in 3 already have prediabetes, and a lot of them don't even know it. We find this out when we run programs, and we find out people that have prediabetes or even diabetes and didn't even know it. One of the things that's very interesting is that, as you can see in this graph, it has our weight issues in the United States, and it talks about overweight men and women, and obesity in men and women, and extreme obesity in men and women, as you can see on these graphs. What the biggest change since 1976 to 1980, and maybe we can address this issue as to why that was in the questions and answers, is that starting around that time, there is this dramatic increase in obesity. You notice that the overweight men, overweight women is staying about the same, but the incidence of obesity is markedly rising to now equal the incidence of overweight or exceed it. And then the extreme obesity, that is body mass indexes of greater than 40, are starting to climb as well in that same time period. So that gives us kind of an idea that maybe there's some relationship between the two. As we see here, also started, this graph only goes back to 1980, but we see an increase in the incidence of diabetes in white, Black, and Asian ethnic backgrounds up to the present time. So this graph really was dramatic for me when I saw this one. To the right of this, the right graph, the relationship between weight gain in adulthood and the risk of type 2 diabetes in men and women. And you see that at the 0 point, where the weight changes at the bottom at 0, as you go to the right in weight gain, 5, 10, 15 kilos, we're talking about then 11, 22, and 33 pounds, that the relative risk of type 2 diabetes dramatically increases. So just a weight gain of 11 pounds doubles your risk of type 2 diabetes. Adding 22 pounds gets you up around tripling or quadrupling your risk, and 33 pounds dramatically increases your risk by 6-fold. We're talking about 600% of relative risk. And this was very fascinating to me, because some studies have shown that if you lose 33 pounds, that you can get rid of your type 2 diabetes. So these things kind of match up with each other without even knowing that they were even related. Now, diabetes tends to focus on sugar. And that's because the criteria for diabetes have to do with things that involve sugar, whether it's your fasting blood sugar, your 2-hour blood sugar after glucose challenge, or your hemoglobin A1C, which has to do with the glycosylated or sugar-coated hemoglobin in your red blood cells. And so what you have here are, in the red, you can see a stage 3 has the criteria for prediabetes, and then you have at stage 5, you have the criteria for actually having full-blown diabetes, whether it's the fasting blood sugar, 2-hour blood sugar, or the hemoglobin A1C criteria. So the only reason for looking at these is because of when you're trying to decide, well, has someone actually reversed their diabetes or not? So if you have criteria for having prediabetes and diabetes, you can then not meet these criteria for having them. Now, there are different kinds of diabetes, the type 1 insulin dependent, where you really require insulin, hopefully not very much, but you still absolutely need it. We're going to talk about type 2, which is non-insulin dependent, and sometimes insulin has to be added for the management, but they're not absolutely insulin dependent like type 1 is. So we're going to talk mainly about type 2, even though there are many principles that would apply to having both. So someone who has type 1 diabetes can still gain some advantage or good information from what I'm going to tell you about today. So the reason why diabetes is such an issue is because of the small blood vessel damage that occurs. And these involve then different parts of the body. And depending on the part of the body where the blood vessel damage is occurring, it gives you the symptoms in that part of the body. So with the retina, it's causing blindness. With the kidneys, it'll cause chronic kidney failure and disease, and require ultimately either transplant or certainly dialysis in the meantime. There is a neuropathy that occurs because of the effect on nerves, leading to pain or numbness. And then there are the peripheral vascular system affecting the skin and particularly lower extremities, which can cause problems with wound healing, susceptibility to infections such as gangrene, and even requiring amputation for the protection of the life of the individual. So these are obviously not very good endpoints and something that people want to try to avoid. Well, historically, there was this mindset that there was no cure for diabetes, even stated by the American Diabetes Association. Also from the National Library of Medicine, that this is a lifelong problem. There's no cure. From the prestigious Mayo Clinic, there's no cure for type 2 diabetes. Well, back over 40 years ago, 1979, Dr. James Anderson from the University of Kentucky presented some evidence of a high carbohydrate, high plant fiber diet to treat insulin using type 2 diabetes individuals. And so he had a group of 20 who were receiving insulin treatment for their type 2 diabetes. And what's interesting in that in a matter of 16 days, half of them were able to come off of insulin. Some were up as high as in the 32 units of insulin a day. And so sure, there were some interesting other side effects in regards to their lipids, but this showed for the first time that people could come off of insulin altogether. And this was in a short period of time. So the other things that started building evidence for the reversal of type 2 diabetes is from the bariatric surgeons. And after a meta-analysis of a number of studies regarding bariatric surgery, they saw that diabetes, where the surgery was just for weight loss, that diabetes was completely resolved in 77% of the patients. Quite a remarkable feat. And so because of this mounting evidence, then there was people like Joel Fuhrman, who said, we won't be controlling your type 2 diabetes, we'll be having you become undiabetic. And then, as was alluded to, Dr. John McDougall, a pioneer in lifestyle medicine and the starch-based diets, said a simple cure is possible for essentially everyone with type 2 diabetes. Well, how could they say that? That's such a remarkable thing to say. Well, finally in 2009, the American Diabetes Association changed their mission to include some interesting change in words: to prevent and cure diabetes, and to improve the lives of all people affected by diabetes. So now they say that there is a cure. Well, how do they define cure? Well, interestingly, they didn't even say the word cure. They would say things like remission, like much as we use for cancer. So partial remission was basically getting the glycemic numbers into the pre-diabetes range for over a year, and without the use of any drugs or procedures. That was partial remission. Complete remission was if you no longer met the criteria for even pre-diabetes, and so that you had normal glycemic measures for at least a year without the use of any drugs or procedures. And if you were able to maintain this complete remission state for 5 years or more, then they would say you had prolonged remission. They're still not saying that you're cured, but we'll take that, even if we have to take that. So what was their, as you look at it, why was it so reluctant to say that you could cure this? Well, in 2014, Diabetes Care had a study in regards to the remission of type 2 diabetes in the community. And they're looking at over 100,000 people receiving what we call the usual medical care. And what were their results that they looked at? After 7 years, how many were able to receive partial, complete, or prolonged remission during this 7-year period of time? And it looks pretty dismal. Partial remission, only 1 to 2 out of 100. We're talking about 1 to 2%. Complete remission, this was just for a year now, was a little over 1 in 1,000. And the prolonged remission was even lower, less than 1 in 10,000. Now, if I was going into medicine and I looked at that as usual care, and that was the results I was getting for usual care, it would be enough to make me quit medicine. So these are pretty lousy statistics. And yet, in 2018, Dr. Wes Youngberg, he looked at a program for 16 people. If you'll notice that their hemoglobin A1C at the beginning of this 3-month program was 7.7, which is clearly in the diabetes range. And after, their average hemoglobin A1C was 6.0, which is more in the pre-diabetes range. But they saw that 67% reversed their diabetes. That is getting close to the bariatric surgery numbers. So you can see that with a different type of care, a different type of education and application, that there could be much better rates of diabetes reversal compared to the usual care. So what's the problem? And why is it that standard care isn't that effective and other methods are getting better results? So as we look at the concept of high blood sugar, there's a very key player, and that is a hormone called insulin that is made by the pancreas. And insulin helps to control blood sugar. Now, on the right, you see a picture of a key in a lock. And we can look at insulin as sort of a key in the lock to help open up the cells to receive glucose, blood sugar, into the cells for use for energy. Now, the mechanism of insulin resistance is what we really want to address. That is the real main issue in type 2 diabetes. Whereas type 1 diabetes is a total lack of insulin production, type 2 diabetes is a problem of insulin resistance and can even result in oversecretion or higher than normal insulin levels. And so insulin resistance is the body's normal response to an excess of calories and a particular class of calories. But this is the body's normal response. It's saying enough is enough. And it's okay if this happens an occasional meal or an occasional day here and there, but when it's happening 3 times a day, 7 days a week, 365 days a year, then the body is not going to be able to adapt to this very well, and there are consequences. So what we have here is going into the stomach. We'll talk about carbohydrates. They will be digested, and glucose gets into the blood vessels. And as the blood vessels are filled with glucose coming in, the blood sugar level starts to rise. The islet cells in the pancreas, an organ in the abdomen, secretes insulin to say, okay, folks, you cells, get ready. We've got some glucose coming in. I'm going to open you up so that you can receive the glucose. And this amounts to lowering the blood sugar because the sugar is going from the blood into the cell. And so there's a kind of a complicated process, but you can see insulin on the right, which is kind of the key in the lock, which starts when it attaches to the receptor. It will start this mechanism by which glucose can then be transported inside the cell. And so it's a very complicated thing, but what happens is that this process of once the insulin is trying to initiate the process can be gummed up, and it's usually gummed up with intracellular fat. And so we have this whole cascade of what's called insulin resistance. And it's that as more insulin has to be secreted in response to high blood sugar levels for whatever reason, that there's insulin promotes more weight because it helps facilitate fat going into fat cells. Obviously, as the fat cells get fatter, they will release the fats back into the blood. And because insulin tends to stiffen arteries, the blood pressure will tend to rise. As what happens is that fat gets into the bloodstream even faster than glucose. And so you get a flooding of high fat meals into the bloodstream, which then goes multiple places. Obviously, it can go into fat cells, but it can go into muscle cells and liver cells in particular. And so when you see the whole effect here of fat going into places that don't really usually store fat, fat cells are designed to store fat and a certain amount of fat, but we have fat going into muscle cells and into liver cells. Then we have dysfunction. We have a buildup of insulin resistance because these cells are saying, we don't want any more. We have enough intracellular energy. We don't need any more. Please don't send us any more. And so they start, it's the body's defense against all these excess calories coming in. And what we have here is a gradual rise in insulin, because as the cells are trying to say, no, 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 the body's saying, yeah, but our blood sugars are going up. We need more and more insulin. And so there's more and more insulin being secreted to try to overpower the insulin resistance. And as these, particularly the liver cells say, oh, well, they're pumping out glucose. And so now that it becomes resistant to insulin, it doesn't realize the signals that the body is giving to say, we have enough sugar, and instead the liver keeps pumping out more glucose. And this is really noted in the fasting blood sugar levels, where you have really abnormally high fasting blood sugar levels than you need. The fat cells, unfortunately, are getting so overblown in a way that they start calling for help, needing inflammatory cells to come in and help gobble up the extra fat, but they also then can rupture, they can release fat back into the bloodstream, which causes all kinds of problems in your blood tests in regards to lipids. But the other effects is that they dump back into the bloodstream fats that then try to go back into other cells and organs, and in particular the pancreas last of all, where it tends to then cause damage to the beta cells. We call it lipotoxicity, where the fat in the beta cells will cause premature beta cell death. And so at this point in time, when the beta cells are starting to die off, then the body's ability to compensate with extra insulin starts to diminish, and then the person needs to have insulin supplied from the outside in the form of injections in order to make up this deficit just to control the blood sugars. So as you see the natural history of non-insulin dependent diabetes mellitus, you start from the left having good glycemic or blood sugar control. There's the onset of obesity. And then with that insulin resistance, you get some glucose intolerance on tests, either high fasting blood sugar or a too high of 2-hour blood sugar, or starting to get some hemoglobin A1C rise to have pre-diabetes levels. And you can see at the top that the amount of insulin in the body, in the bloodstream that can be measured is starting to go up. We get a process of hyperinsulinemia. It's just that there's more insulin needed to do the same job. Then they finally starting to lose control altogether, and we have diabetes with high insulin levels. And then as you go further right, we get obesity with low insulin because the beta cells have been damaged and they are producing less insulin. And this sometimes requires exogenous insulin to be supplied in order to control the blood sugars. So when we have high levels of insulin, as we said before, insulin promotes even more weight gain. It stiffens the blood vessels, so it causes elevated blood pressure, and it leads to basically an increased heart attack risk. So when you have type 2 diabetes, the greatest single cause of death in type 2 diabetes is a heart disease. And your levels are at least 4 times the risk when you have type 2 diabetes of having a heart attack versus the people that are just eating the standard American diet. Even at pre-diabetes levels, you have double the heart attack risk from the general population. So one of the ways that people try to promote treating diabetes is the ketogenic diet. And the way I look at the ketogenic diet, it is, again, just another one of the methods of treating symptoms. It does not address the underlying cause or the problem. We said the underlying cause of the problem is insulin resistance. Ketogenic diet is no more than a dietary manipulation to do what some of the drugs that are available for diabetes have been doing. So we have drugs that can reduce the ability to digest and break down starch into glucose. So basically reducing the glucose coming into the body. We have drugs that can increase the amount of sugar excreted in the urine so that you can pull down the blood sugar levels by dumping out more sugar through the urine. And so this is just a fancy or dietary way of manipulating lower amounts of carbohydrate coming into the body in order to keep blood sugars low. And does it work? Yes, it works. People will say my hemoglobin A1C is low, it's normal now, or my blood sugars are really good all day long. So remember, insulin resistance is caused by the storage of excess fat in tissues that were not designed to store large quantities of fat, namely the muscle cells and the liver cells and the pancreas. And that, as we already talked about the sequence of events of insulin resistance, as you see here, do any of these steps talk about sugar or glucose or carbohydrates? No, it's all about lipids, fatty acids, adipose tissue, lipotoxicity. So because you have excellent blood glucose control does not prevent you from having increased tissue inflammation and chronic disease. In fact, the deceptive part of the ketogenic diet is that you have short-term improvements, but you're going to have long-term side effects. So initially, you will have improved blood glucose control, reduced hemoglobin A1C, and some weight loss, and maybe even some reduced blood pressure because you're not going to have as much insulin because there's just not as much glucose around. But at the long-term effects are increased muscle insulin resistance, liver insulin resistance, the pancreas beta cell insulin resistance. You're going to have extreme carbohydrate intolerance. You're going to promote these beta cells that produce insulin to die off. Eventually, you will have problems with high cholesterol and hypertension. These are the long-term side effects. And increase all-cause mortality. Now, this is what's so deceptive about this, is because they develop such insulin resistance, because they haven't addressed the problem of insulin resistance, that there is increasing carbohydrate intolerance. What does that mean? That means that any little bit of carbohydrates you get just blows your blood sugar up remarkably more than normal. And so that just reinforces the people to say, see, I need to stay on this low carb diet. I can't take any carbs. And it's true, they can't take any carbs because they've developed such carbohydrate intolerance from their insulin resistance. And their insulin resistance has not been addressed, even though they had improved blood sugar control and lower hemoglobin A1C. And we see that dietary protein can even have an effect on blood sugar control, but usually later, 3 hours to 5 hours after it's been ingested. What we see is that protein and fat have additive glycemic responses. So here you have someone getting a meal with a certain amount of carbohydrates, the same amount of carbohydrates every time, and then you have different manipulations of the grams of fat and the grams of protein added to that meal. So you can see that the peak blood sugar at time about 60 to 90 minutes is the same in both, in all of these combinations of meals, because it's the same amount of carbohydrate going in. But with the addition of more fat or more protein, or with the addition of extra fat and extra protein, what happens to the blood sugar? Well, what you see here is that the lowest is when you have low fat and low protein. The blood sugar comes right back down. Now, it doesn't matter whether you have increased fat added or increased protein added, the effects are about the same. They slow down the clearance of blood sugar out of the blood. And with both fat and protein added, there's hardly any lowering of the blood sugar out about 5 hours after the meal. So this maintains a high blood sugar level. So what is the solution? So what we would propose is a low-fat, plant-based whole food nutrition, which has been talked about all morning long. What are its effects? It reduces insulin requirements. It reduces the oral medication requirements. It increases carbohydrate tolerance. It significantly improves the blood sugar control. It reduces the beta cell lipotoxicity. It reduces your risk for many chronic diseases and reduces your risk for all-cause mortality. So all good things. If you compare these three, here you have a ketogenic diet on the left, the SAD or the standard American diet in the middle, and the low-fat, plant-based whole food diet on the right. You can see at the top that the ketogenic diet gives you good glycemic control, but you have insulin resistance and you have high chronic disease risk. Whereas the standard American diet doesn't do much for your blood sugar control, probably does induce some insulin resistance, and you have a high chronic disease risk, as Dr. Megan told us about this morning. And then on the right, with the whole food, plant-based, low-fat diet, you have good glycemic control, you have insulin sensitivity, and you have a low chronic disease risk. And so obviously, what you're seeing here is a benefit to the low-fat, whole food, plant-based diet. As Dr. Sarah talked about, what does the brain need? The brain needs glucose. It sucks up 20% at least of your glucose that you ingest. and it functions best on that fuel. And so when you're talking about a very low carbohydrate diet, it seems to be moving in the wrong direction for brain health. And then those who have promoted a high protein, low carbohydrate diet, AKA paleo or the Atkins diets or some of those things. And again, they have problems with elevated cholesterols, a chronic kidney disease risk due to the kidney damage induced from the acid loads, from all of the amino acids from protein, particularly if it's animal protein, increased risk of cancer because increased levels of insulin growth factor 1 occur in response to high protein diets. You have increased calcium loss because of all the amino acids and the acidemia that is produced needing to be buffered by the body, and that is the buffer is promoted in the form of removing calcium and phosphorus from the bones to buffer that acid. You get more long-term insulin resistance and disruption of the microbiome from very poor low levels of fiber, which was mentioned before by some of our presenters on the importance of fiber, which only comes from plants and usually those with carbohydrates. So as we said before, that the key piece is insulin resistance, and that what's been shown that these high-fat diets or the high-protein diets, they either have no change or increases in the intramyocellular fat, which is the cause of insulin resistance. So they are doing nothing to affect the root cause of the problem. What we would recommend to reverse type 2 diabetes is a lifestyle approach. What Dr. Megan was telling us about was a holistic approach, most of which has to do with the diet, because one of the things you're trying to address is the intramyocellular fat and reduce that. And so that got there by dietary means, and it can be reversed by dietary means, but there are other things involved as well. But in this dietary guidelines, there's again the emphasis on the whole food, plant-based, low calorie, low fat diet with whole grains when they're used. And really, there's a whole thing about the hierarchy of grains, but that's another topic. Getting fiber, and I would even up Dr. Stevens' fiber thing up to 45 grams a day, even higher than the 35. I mean, the average American gets about 10 or 12 grams of fiber a day, pretty low. We try to teach them to get more legumes into their diets, to increase the quantity of raw nuts and seeds, to have low saturated plant fat from even the plant sources, to have a wide variety of colored vegetables, eating the rainbow, as was stated earlier, and foods that have a lower glycemic load and not much sodium. And then in the other lifestyle things, again, we're trying to attack insulin resistance, and it's been found that exercise will reduce insulin resistance. Stress reduction will reduce insulin resistance. Optimizing sleep, as Dr. Sarah was talking about sleep, will reduce insulin resistance. You can have one poor night of sleep, 5 or 6 hours of sleep, and your insulin resistance goes up immediately. And having regular support, social engagement is also another way to help improve one's not only just adherence to changes, but also that which happens to the brain and the mind in response to this also helps reduce insulin resistance. So we have been doing a program now for about 4 or 5 years called Diabetes Undone. We've kind of call it now Diabetes Undone Plus. And it's a program an 8-week program that meets once a week on usually Sunday afternoons. It was developed by Dr. Wes Youngberg, who does video presentations along with a dietitian named Brenda Davis, who's written a lot of books on whole food plant-based nutrition, but specifically she addresses diabetes. And we measure people as they come in, both in biometrics and in laboratory tests. We do cooking demos, exercise nutrition, talk about all kinds of things, including Dr. Stevens' thing on food label reading, choosing the right foods from reading the nutrition labels. We talk about calorie density. We talk about all these things, some of the things that you've been kind of introduced to today. And we package that up into a program that has been pretty successful in the years, the latest times that we have been monitoring this in the 8 weeks. About a third of the diabetics become pre-diabetic. A third of the pre-diabetics are no longer pre-diabetic. And so that's just in 8 weeks. Actually, it's 7 weeks from the time that we start until the time we measure the second time. So we feel that it's made quite an impact, and we think that's the way to go. We'd also, if you want even more information in regards to diabetes, you can take in the whole conference, which has been mentioned before. Dr. Cyrus Kambata is one of the presenters. He's going to be talking about, he's the developer of the Mastering Diabetes online program, and he will talk about using a low-fat, plant-based whole food diet in regards to diabetes. And so you can get a lot more details in that one. But if anyone is interested in, or you know of anyone who could use some help with type 2 diabetes, we are going to be having an information session on January 17 and also February 21 following the whole conference. If people are interested, they can just come and we'll have a Zoom information session so they can find out about the program, see if they want to sign up. And if they're interested in the info session, take down this phone number or email, telephone number, and then also the email, and say that you want to attend the information session and check it out. So that's all I have. Be happy to answer any questions.
Dr. Lowe, that was so wonderful. Thank you. And for those of you that don't have time to get that information down, we'll be sending you a packet out in the mail, and these flyers will be included. So the flyer on the whole conference and also Diabetes Undone. If you don't mind, I'll take the ball back for, I'm sorry, before I'll get to that at the end, I just wanted to introduce, there's another flyer for Dr. Lowe's programs that will be sent out in the packet as well. But if I can ask Dr. Lowe, I know we're running over time here. So for all of those that want to stay for the questions, please do. I don't think we'll be too much longer over time. What would you say to a patient in this common situation that they learn about whole food plant-based and they want to do it, but then they check with their doctor, if they have diabetes in particular, they check with their doctor, and the doctor, they're told by their doctor that no, they can't do that, or no, don't do that, it'll kill you, or something else similar?
Well, all the people that come in, if they're being followed by a physician, which practically all of them are, we want them to stay in touch with their physician. We want them to work with their physician, but we also want them to inform their physician that they are going to be starting a program which could markedly change their medication needs quickly. And so that they need to know, are you going to be available? Are you going to be with us? And it's something they just want to try. The only danger of it is if their blood sugars drop or their blood pressures drop too rapidly, yeah, they could get into serious trouble. So that one of the first things that we talk about in the class is, one, they have to be able to have frequent contact with their physician, but two, they also need to be mindful of their medications. And we start telling them that they may need to change those rather quickly so as to avoid getting into trouble. It's going to be better to run loose than it is going to be to run too tight.
Wonderful. And you mentioned it's something that hadn't been talked about in any other presentation. So if I could please ask, could you tell us a bit more about the effects of diet on our bones?
On our bones. Well, there are a number of factors in regards to, let's say you're talking about osteoporosis in particular. And that is kind of a misunderstood thing, that it all revolves around calcium, and that, well, obviously there's lower amounts of calcium in the bones causing osteoporosis. And so therefore we need more calcium and that's going to fix it. And it's just not as simple as that. As we look at the statistics, America is one of the, as well as other countries, have some of the highest intakes of calcium on the planet. And paradoxically, why do we have some of the highest rates of osteoporosis on the planet? So as you look at some of the Scandinavian countries and America and some of these other developed countries, which have high intakes of calcium, either through dairy or through supplements or whatever else people are getting their calcium, usually dairy, they still paradoxically have high levels of osteoporosis. So it's not that there's a deficiency of calcium intake in the diets. The problem is calcium loss. So we have excess calcium losses from the body, or what we call negative calcium balance. And so no matter how much calcium you dump into a person, they are losing just as much, if not more, usually out through their urine, through the kidneys, and that's causing the problems with either kidney stones or other issues in regards to the kidneys. So there are so many factors that impact osteoporosis. I mean, vitamin K, vitamin D, the intake of caffeine, phosphoric acid from soft drinks, certain soft drinks, high animal protein loads causing this chronic acidemia that needs to be buffered. So there are a lot of factors that tend to play. I mean, even things like smoking, and alcohol, but some of these things kill off the osteoblasts that are helping to form new bone. So bone is not static. Bone is something that's in flux. It's being built up. It's being torn down as we speak in your body. It's remodeling. It's replacing. It's a dynamic thing. So it's something that can change. It's not like we think of it as a bank. It's just very static, and it's just, you just have a bunch in there, and then you can take it out over time. You can always add. You can always slow down the losses. You can speed up the losses. You can add the deposits. It's just more of a dynamic thing that can be affected by one's lifestyle.
Thank you. And you had mentioned at the beginning that there was a dramatic increase in obesity and diabetes back in the 1980s. Would you mind mentioning about that a little bit?
Yeah, I don't know. Let me see if I can find this slide. I just happened to find it, and I thought it was, let's see, I hope I don't kill myself here. See if I can, am I still on?
You're on.
I'm still on. Okay, see if I can find this slide.
While Dr. Lowe's pulling that up, I'll put in the chat here the website again, where you all signed up for this summit. We'll have some more information on there. And again, we'll put the information about the whole conference in particular. I had a slide, but I won't take our time to pull it up right now. The speakers that he has come are just fantastic. They're absolutely top notch. They're the ones that we as professionals pay mega bucks to go see speak and learn from. But he brings to us, again in Camarillo, but luckily it's virtual this time. But you'll reducing the risk of breast cancer. It's up to you. That's one of the titles. And another one, milk, does it do a body good? Amongst others. So absolutely fantastic. I can't say enough about it, especially for the low price that it is. So I think right now it's $59 per computer. So even
Right. Right. So can I share a screen? Can you give me a way to
we
share the screen?
we see what you see.
Oh, you see what I see?
Yep.
How the American diet has changed
Yes.
since 1970? Okay, so this one I ran across. And so we have, interesting enough, we think, well, you know, type 2 diabetes, sugar, 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 sugar. Well, look what's happened on the left. What we're eating less of since 1970 to 2014. The refined cane and beet sugar has gone down. Potatoes have gone down. Beef has gone down dramatically. However, which I'm shocked that potatoes have gone down, but with French fries and all, but anyway. But the other things have not gone down so much: eggs, milk, full fat ice cream, and margarine. I mean, not that much. But look on the right, what has gone up. And the one, and I call them the 4 C's, which has left with, which has caused the 5th C, which is catastrophe. We have chicken, we have cooking oils, we have corn sweeteners, and we have cheese. What do all of those things have in common? Fat. It's just, chicken is no longer a low-fat option. It has been genetically modified now to be 20% fat. The chicken back in the 1900s, early 1900s, did not have that much fat. They had maybe 5% fat. And so we were saying, oh, that's good. That's a good low-fat alternative. But no longer. The chicken has been genetically modified to be 20% fat. So with the dramatic rise in chicken, and that's what has caused a dramatic drop in beef, we've substituted chicken for beef, but we have not gotten healthier. We've gotten fatter. Cooking oils. That's why when Jay is talking about not cooking with oils, well, cooking oils is not just what you cook at home with, but it's what's being added to all our foods when you eat out, particularly fast foods, whether it's French fries, whether it's restaurants, whether it's processed foods, all the oils that are being added to the foods. The corn products, either products or sweeteners, particularly high fructose corn syrup, and then cheese. So really those all have pretty much in common increase in fat. And so that's why I think along with around 1970, the rise in fast food places to eat, the chains just started multiplying. It just dramatically increased the amount of fat and calories that the American diets are containing. It's cheese has gone way up, and it's primarily probably because of pizza. Pizza now makes up 1/6 of all meals in the United States. 1/6. So that means a pizza every 2 days in the average American. And I don't have any, so somebody is getting it 1 out of every 3 meals. So it's incredible to me how much cheese has gone up. Is because it's been pushed in either foods, particularly in pizza. So it's no wonder that we have this high incidence of obesity and concomitantly a high incidence of type 2 diabetes.
We have one last question, Dr. Lowe, and then we'll let you all get out for some exercise and lunch. Is insulin resistance completely reversible? If yes, about how long does it take if you stick to a whole food plant-based diet?
Well, as you can see in Dr. Anderson's studies, even within 16 days. I remember Dr. Greger gave a talk, and it was something like, I think the fastest someone got off of insulin was something like 12 days or some just low number. And, you know, the amazing thing, and that person I think had diabetes for 10 years. Now, obviously it gets harder and harder to reverse the longer you go because of what can happen with a beta cell death. So the longer you go with type 2 diabetes, the higher risk of beta cell death, so that you don't make any insulin. The other thing that's very interesting to me was that a doctor in London, I can't remember his name, has talked about reversing type 2 diabetes, and he was really for losing a significant amount of weight, that 15 kilos of weight, they could virtually cure everybody's diabetes. However, what they were saying is the longer one goes out, which is interesting, the longer one goes out, like beyond 4 years, it gets more difficult, which is interesting factor that the sulfonylureas that are commonly or were commonly used to treat type 2 diabetes, that after 4 years, they promote beta cell death. And so people that are on sulfonylureas should be getting off those if they're getting close to 4 years of therapy. So very interesting how some of these statistics start to match up with each other and start reinforcing each other. And so what we know now is that many of the medications that are used for type 2 diabetes none of them address intramyocellular lipids, and they are all symptomatic in trying to just reduce the levels of blood sugar. That's all they're doing. And so that's why, in fact, some of them have side effects to where they add to weight gain. They're going to increase insulin resistance. And then you're put on other medicines to control your blood pressure, which can also compound your effects on your diabetes control. Or you're adding statins because of your risk of heart disease. And so all of these other medications that are added are not helping the control of the diabetes and increasing the problems with insulin resistance.
Thank you so very much, Dr. Lowe.
You're welcome.
It's such an honor and a pleasure to have you with us today. So this is the whole conference. Again, you all will be getting this flyer in the mail. Expect an email from us if we don't have your full address. And if you would like to receive the packet in the mail, we just need to make sure we have your full address. So it's going to give you information on Dr. Lowe's programs. We have printed versions of this plant-based nutrition quick start guide. It goes over a lot of the myths and questions that people have when they're looking at transitioning over to a more healthful, whole food, plant-based diet. It's a great resource. So we'll be sending that along. And flyers on plant-based for life and walk with a doc, of course. And here's the website again. We'll have more information out there. And thank you again for coming. Happy Saturday. Well, I'll head out for a walk. So we'll log off now. Take care.
All right. Thanks, Megan.